Good afternoon. After the medico-legal brainstorming, we haven't done any brainstorming. I don't know how many questions to put forward to Professor Rao when he stated the latest statements which looked so irrelevant that I don't think ART can survive if these laws are there. Well, I'll take you to another section of ART considerations in special conditions. And I'm going to discuss few topics. One is sex chromosome aneuploids, which means a wrong number. And we're going to discuss two topics under this, Turner syndrome and Klinefelters syndrome. And then disorders of sexual development. One is androgen insensitivity syndrome, 46XY gonadal DisGenesis, also known as Swire Syndrome, and then 46XX gonadal DisGenesis or agenesis. So one is XY dysgenesis, one is XX dysgenesis, and we'll see what are the differences in these. So the most important thing is to know how sex chromosome aneuploidy comes up, and it is just a female gamete which may not separate out the two from the chromosomes, the two centromeres, and what it may form is all the four combinations which you can see here. Do I have a laser pointer here? Okay. No? Okay. Well, you can see there could be a triple X, there could be a XO, there could be XXY and OY. What are we going to look at today? XO, which is Turner's, and XXY, which is male Klinefelters syndrome. Female triple X survives with little problems and OY is not viable. So Turner syndrome, genetic causes, well, it is named after Henry Turner, endocrinologist. And the genetic causes, there are three categories of Turners. One is absence of X chromosome in all chromosomes, all cells. In all cells, the X chromosome is absent. Two is absence of X chromosome in some cells only, which is known as mosaicism. And generally, 45X may be 10%, 46XX may be 90%. And hence, there are few features of Turners at some organs, but not everywhere. And the last is defect in one X chromosome in all cells. So now this one could be either fragmented, or portions could be deleted, or ring formation could be there, preventing normal expression of X chromosome gene. So what happens when we have mosaics? Absence of X chromosome in some cells. It's not all cells. So you would not get all features of Turner's. Diagnosis is by examination of blood cells, but not very easy because you may not come across a mosaic cell in that. But then skin and buccal cells are better off to detect all type of, both the combination of these cells. These children may experience normal pubertal development, regular menstrual cycles, and spontaneous conception compared to the 45X pure monosomy. Mosaic diagnosed by karyotype analysis. Why? How do you come to diagnose? They have their periods, they grow normally. Suddenly, what comes to your mind that you think that they have mosaic Turners? Then you have a history of RPL, early pregnancy losses, repeated IVF failures, and the rate of mosaicism is about 2.6 in RPL. Turners who have spontaneous menstruation and ovulation need to counsel. Once you find out there's Turners, then it's very important to think that quick reproductive, one needs to finish off the reproductive function of theirs or desire because of the risk of POF. Now, if you look at this picture, it's a very, very nice picture and very understandable. This is a chromosome, a 1X chromosome. What happens? It has a long arm, it has a short arm. If you have a partial reduction, which means if you have of the short distal arm, then this Turner would be will have all the phenotypic pictures of Turners. Whereas if the long arm is absent, it will have all the reproductive features. If both are absent, it will have both features. So this is what happens in the third subgroup where I said all cells are Turners, but then one arm is missing or a part is missing. So what is fertility in Turner syndrome? Current parenting options include spontaneous conception, especially in mosaicism. Then we all understand donor oocyte and ART. And then surrogacy is also an option in here where they have other physical characteristics, especially cardiac, where we feel the woman may not be able to carry a child through. Now, Donor oocyte is a very easy option if there is no other physical barrier to conception. But homologous fertility preservation includes cryopreservation of the patient's own gametes prior to progressive ovarian atresia. So in the beginning, there is not so much of ovarian atresia, and lucky are those children where Turner's is diagnosed at an early age, because they have a phenotype which matches Turner. And here we can probably save some of their ovarian tissue or some of their oocytes. The only thing is, when we have mature oocyte cryopreservation, we need to stimulate these ovaries. But if we have ovarian tissue cryopreservation, it can be done much before the whole ovary is lost. If they don't have any functional ovaries, then we all understand it is either oocyte donation or embryo donation. Special attention should be given to appropriate preparation of the uterus with estrogen replacement and progesterone withdrawal. Ideally, only one embryo should be transferred in these girls, because they really have a small uterus and we cannot give them the risk of a multiple pregnancy. Now, pregnancy issues are there, and therefore, as ART specialists have full responsibility of making sure that whoever is going in for oocyte donation is likely to continue the pregnancy without any increased health risk to her life. And one is that because they are small, these girls, they are short in height, where there's a very high incidence of cesareans. Hypertension and diabetes are common in these pregnancies. Thyroid status and glucose tolerance should also be monitored. The most critical thing which should be seen in all girls going in for oocyte donation and pregnancy who have Turner's is whether there is a aortic dissection or coarctation of the aorta, because this progresses very severely during pregnancy and may lead to lethal problems. We come to Klinefelters. Now, here what happens? How is this disorder inherited? There is non-disjunction of the two chromosomes. An egg or a sperm has both the chromosomes and it combines with the other partners, one chromosome or one centromere which has converted into a chromosome. So the embryo has 3 copies of a chromosome which becomes XXY. Now if it was XXX, it would have been a super female which has a very different type of problem and is not like this, but XXY makes it a man with problems. And between 1 in 500 to 1,000 males have Klinefelters, and infertility, well, Klinefelters is much higher, and 3% would have Klinefelters. Fertility management is on the basis of non-obstructive hypergonadotropic azoospermia. So they come with testicular failure basically. Reproductive genetic counseling of patients with 47XXY karyotype remains difficult. Microdissection, testicular sperm extraction is done, and it can be done before complete hyalinization of the testicular tissue has happened. So again, early diagnosis is the key to success if we want to get some gametes or some testicular tissue on which gametes could be developed possibly later, is only when complete hyalinization has not occurred, much before probably the reproductive question comes in the mind of the couple. First such child was born in 1997 using ICSI for a non-obstructive mosaic Klinefelters. So this is very important, that mosaicism gives a lot of hope, but pure Klinefelters are generally so azoospermic, and by the time we know, we've lost all hopes to gain any sperm anywhere. Now, sperm or spermatogonial stem cell banking, which is known as SSC banking, one word about it. Germ cell depletion begins at onset of puberty and leads to infertility. Therefore, if we can bank sperm stem cells, we would probably preserve fertility for these men with Klinefelter syndrome. And we have to retrieve them by testicular biopsy before testicular hyalinization, like I told you earlier. For those who still do not have azoospermia, before starting testosterone replacement therapy, sperm cells may be collected after ejaculation and frozen for future use. Better option for men again with mosaicism. Pure Klinefelters, very difficult to get sperms. What is the future if one has mosaicism of Klinefelter syndrome? 10% of patients will have mosaic form, and this is a random event in cell division, early in fetal development. Thus, there are 2 cell lines. Like one cell has got 3 chromosomes and one cell has got 2 normal chromosomes, and hence a mosaic develops, and they have less severe signs and symptoms. And those who have mosaicism cell lines will have normal cells also, sperm cells also, and we might find sometimes 1 or 2 cells in the ejaculate, and therefore when there is severe oligoasthenospermia, we do think of doing a karyotype always, and we might unreveal mosaicism, especially mosaicism of this syndrome. Is there any role of pre-implantation genetic diagnosis in the offspring if we are using sperms from such men? There is, it is recommended, because again there is an incidence that some of the embryos will again have the Klinefelter type of structure, but then PGD cannot guarantee, because those 2 to 4 cells even which we take from day 5 embryos, if it is a mosaic, again might miss out on whether this is a pure Klinefelters or there is mosaic or this is a normal cell. So we might give a report that this is normal because we've got the XY picture or the XX picture in the baby. It's a male child who would be affected, so XY. But then there would be still some cells with XXY. And hence PGD cannot guarantee, but gives us a lot of hope that we are probably selecting the right embryo for transfer. Then I come to the second section of my talk, disorders of sexual development, and I've been asked to speak on androgen insensitivity syndrome, 46XY gonadal dysgenesis and 46XX gonadal dysgenesis or agenesis. Now I want to clarify one thing very, very nicely, that you have to understand that the usual pattern of human fetal development results in a 3-part alignment. First, the sex chromosome is made as soon as an embryo forms. It's either XY or it is XX. The XY will have gonads to develop. The XX will have ovary, gonad as testes to develop, XX will have the ovary. When testes develops, it will produce external genitalia which would be male. When an ovary develops, external genitalia would be of a female. Now keeping this in mind, what happens in androgen insensitivity syndrome and Swire syndrome, because these are both XY females. In Swire syndrome, a gonad, a part of the gonad, the SRY area does not develop. So because the SRY region is absent in the Y chromosome, and hence there is no production of testosterone and there is no production of AMH. No production of AMH lets the uterus and tube develop. Why? Because there is nothing to antagonize Mullerian development. On the other side, there is no androgen, and hence the phenotype is female. The male organs do not develop. On the other hand, look at androgen insensitivity syndrome. Here the gonad is again testes because it's XY, but the SRY region is also there, so it will produce both the hormones, it will produce AMH, it will produce androgens or testosterone. But the X part of the XY chromosome has a genetic disorder which makes all receptors for androgen insensitive to androgen. And hence no receptor in the body would recognize this androgen, and hence there would be complete feminization. On the other hand, because AMH is present, it will not let the uterus and tubes develop. So in Swire's syndrome, there is a uterus, whereas in AIS, there is no uterus. So they are girls with no uterus. They develop as phenotype girls with no uterus, whereas both are males when we look at the genotype. So in short, what is AIS or testicular feminization? Presence of XY chromosome, presence of male gonad, partial or complete feminization of external genitals. And why does all this happen? Because there is inherited X-linked recessive disease. This is in the partner of the Y chromosome. That is, the X chromosome, which is the sex chromosome, has a recessive gene disorder which results in a functioning by X chromosome, whereas the X chromosome has a mutated androgen receptor gene which alters androgen receptor sensitivity. So sensitivity is gone, knocked off. Patients have normal testes and produce normal AMH and T4. AMH inhibits formation, I just told you, of fallopian tubes, whereas peripherally testosterone does not act on the genitals, and hence there is no development of the male organs. Now look at this, what happens, the mothers are always carriers of this, nobody else can be a carrier of this. Now if a mother has a baby, the daughter will again become a carrier, but if she has a son, he will have the disease. The XY boy, poor thing, will have external genitalia of a female and will not have any internal organs of a female developed. So this is how it happens. Statistics, incidence of AIS is 1 in 2,000 females, 2/3 inherited from mother and 1/3 spontaneous mutation in egg, whereas Swire syndrome is even rarer and it's a non-genetic cause or it happens from new mutations. No effect on life expectancy. Laboratory diagnosis, very simple, karyotype, XY. Fish, presence of a, we can even do a fish because this is quick turnaround time than conventional karyotype, and increased or normal testosterone and DHT blood levels. DNA test and mutation analysis for androgen receptor gene on X chromosome shows that yes, this is androgen insensitivity because there is a gene on the X chromosome which is mutated. Imaging studies would again confirm that there is absence of tube and uterus in AIS. Treatment is surgery and estrogen replacement fertility issues. Surgery, one important thing is orchidectomy to prevent possible malignant degeneration of the testes, generally done during late teenage or early 20s. Why? Because we want these testes to make some androgen, spontaneous pubertal development under effect of the estrogen produced from aromatization of the high levels of testosterone. So testosterone is being produced a lot. It has no receptors to act. It gets converted into estrogens in the periphery, and these estrogens at least allow pubertal development of the girl. In addition, many women with androgen insensitivity.
We are getting a bit
Yeah, I'm just finishing.
Thank you.
With androgen insensitivity require vaginal lengthening procedures, but now the intersex advocates feel that we must leave this on the choice of the person. We are no one to advocate sexual organ handling of adults. They should, once they get adults, they should decide for themselves whether they want a vaginal lengthening procedure or they are happy to be as they are. Estrogen replacement and fertility, I'll take 2 minutes, is it okay? For complete AIS, estrogen replacement after gonadectomy is essential. No progesterone as there is no uterus, but some breast advocates feel that giving progesterone will probably prevent breast cancer also. Despite incremental estrogen therapy, development of breast and secondary sex characteristics tend to be poor, and donor oocytes with surrogate mother is the only option. In Swire syndrome, it is the same I've just described you, but with normal Mullerian structures and bilateral streak gonads. So with this presentation is delayed puberty or primary amenorrhea due to non-functional gonads. Normal female external genitalia found, normal vagina is generally there, and a normal uterus is also there. Most cases are not inherited. They occur in people with no history of the condition in family. So management for Swires is uterus is present, building up of the endometrium is done with cyclical estrogen progesterone, and IVF can be done with donor oocyte. Whereas on the other hand, the androgen insensitivity syndrome or the testicular feminization, uterus is absent. So we can't have a baby of this girl, neither the eggs are there nor uterus is there, so we'll have to use donor eggs with surrogacy. The last one is 46XX pure gonadal dysgenesis. It is, when you do a karyotype, you find 46XX, but you will find that there's streak gonads, there are almost no gonads, and they present like POF. So these are cases where you find no defect on karyotype and yet there are no gonads. The very important thing here I just want to bring to your attention is on this, that dysgenetic testes have a high risk of malignancy and hence have to be removed. In this condition, dysgenetic ovaries do not seem to increase the risk for malignancy, so don't need to be removed. And the last is management. Again, as it is in POF girls, let the uterus grow. A donor egg is good enough. So summary of the reproductive option is Turner syndrome leads to ovarian failure and oocyte donation, and IVF is the thing for a Turners who can carry a baby. Klinefelters, testicular failure, sperm donation. AIS, dysgenetic testes, so gonadectomy is very important, oocyte donation, IVF and surrogacy because there's no uterus. Swire syndrome, there is a life-saving uterus, so dysgenetic testes, gonadectomy is important, oocyte donation is good for pregnancy. Pure gonadal dysgenesis, dysgenetic ovary, but no need for gonadectomy, oocyte donation and IVF. Thank you very much.